thank you for coming to Georgetown. This is actually the fourth meeting of our work group. So the work group was established in 2016 under the umbrella of U.S. China Dialogue. So this is our bigger program. We are one of the 5 projects under this initiative. So at the time, we're thinking, okay, so U.S.-China initiative, what should we talk about? So global health came up as an interest. So I was asked to chair, to build a work group for this initiative. So I invited my colleagues from Tsinghua University and from Zhongshan University, Tsinghua University, to join me in this course. And we also have our own colleague, Mike Stodo is a core member, and Rebecca Katz, who is actually right now, I think, briefing at NIH, but she will join us a bit later today. I'm also very honored to have lots of support from the university, and today we have 3 wonderful, prestigious speakers as our moderators. So Renee Mashri, I'm sorry, is the director of our Global Health Initiative at Family Medicine at GUNC. And we have Matt, who are coming from the law school, and you're the director for Global Health Policy at our Neal Center. And we also have my chairman, the chair of Global Health Program at School of Nursing and Health Study as our moderator for the second, Dr. Bernard Music. We also have our dean from School of Nursing and Health Studies, Pat, is here with us for a while just to thank you so much. I know this is a busy time. We're all waiting for the grades to get in, right? The deadline is in a couple of days, and actually this morning while I was in the meeting, I got an email saying, graduating, you need to give us the grades. So, and to our guests, welcome to Georgetown campus. This is I would say, the best season for DC before the summer humidity kick in and after our endless winter this year. So thank you for coming in. We will have 2 hours, 3 panels. The first panel focuses on the migrants and healthcare services. The second panel focuses on vaccine development and the pandemic surveillance system. And the third panel focuses on financing on some of these global health issues. So we'll start with the first one. The first panel, we have 4 presentations. So we have, this is the longest one. So we have now till scheduled to 2:50 for presentations and discussions. So I think the format will invite every speaker to talk about their projects for 10 to 15 minutes. And then if you have questions, we can wait till the end of the session, and our moderator will help us to guide our discussions. Thank you so much. Okay, so our first panel and first speaker is, open it up, is Professor Zhang Hong. She's actually a special guest to our panel. She worked with many of us in the work group, and she's from, right now you're from the Gut.
Yeah,
Gut. I'm trying to pronounce, from Belgium, but she has a big EU project in China, several of them actually, but working on the health services for the migrant women.
Okay, thanks. So, good afternoon. Okay, just go quickly. So today I will talk with the reproductive and perinatal health among rural to urban migrants in China and also the immigration women in Beijing, 3 projects. So this is my outline. First thing that I talk about reproductive health among the rural to urban migrants in China includes the 2 studies. One is the UNAMI, that I presented that. And second is the impact study. And the second part, I talk with you perinatal health among immigrant women in Beijing. I taught with you CP study. So first, UNAMI. What is that? This is a summary. Is a young labor migrants in China cities. Is a big study 2006 and 2009. The founding is the European Commission. Maybe some of you know what is the European Commission. It's a framework. So it's under the sixth framework. Is what kind of study? Is a cross-section study. Of course, we are also intervention study, but today I just have the basis land survey. We have time limit. And also population is include near 5,000 female migrants. So outcome is reported health status. Very good setting, 2 cities in China. One is Beijing and another is Guangzhou. The population, I give the chart, is includes migrant near the 4,867, and the age between them is 23rd, near the 24 years old, but the range between the 18 to 29. But the more of the half of them is unmarried. In China, the different situations have the service between married and unmarried, and especially for the reproductive health. Among them, the sexually active are more than half of them. But we ask over past 6 months. But among these sexually active, no contraception use we talk is also near 75%, 2/3. And among them, we also unneeded meet for contraception. What is the definition? That means women who are at risk for the uninitiated pregnancy and not use any contraceptions. How many among them is near 14% among this one? So what is the end, the result? Among the 1 of 4 result, what is that? Uninitiated pregnancy, and ending with the 1 of 5 is abortion. So we also, what is the factor associated with reproductive health? We measure the 4. First, access to reproductive health. Second, access to free condoms. Third, easy to discussion, sexuality. And the 4th is efficient contraception use. What is efficient? That's continue and the correct use condom and also model contraception. So you can see the difference between married studies. You can see married, and you can see the lies among the unmarried is less access to free condom, only among them 24. It's also, you can see the education is a more level education is more easy access, 4 factors, and also easy to discussion sexualities. Health insurance and also is the factors. You have the, if you have the insurance coverage, you have the more access. The factor is more better than without access insurance. You can see the 2 colors. The red color is how to say is unmarried. Another color is education is also red color, which is less than 7 years. And health insurance is blue color is yes, red color is no. So the conclusion, the migrant work was is unmarried, low-educated, and uncovered by health insurance. This population is more, how to say, vulnerable for reproductive health, the 4 factors. You can see these pictures. This is a project we have finished 2006 and 2009. Of course, there are a lot of publications because we are scientific research. This is the outcome. A lot, yeah. We have the more than 5 papers. If you want to the details, you can find the papers. So second project of the impact studies. What is the impact? It's integrating both abortion family planning service into existing abortion service and hospital setting in China. Maybe most of you, in China, the abortion is free, very easy access, and also the family planning is different for the married and the non-married. This study is between the 2012 and the 2017. The funding, the European Commission, we get 3 million euro for this project. The population, we collect the data near the 18,000 women. So it's also question study. Of course, we also the intervention study, the RCT. What we did, the setting includes 300 hospitals in 13 Chinese provinces. That means 10 hospitals from each province. You can see. So you can see the data collected from 2 months, continued data collection for all the women seeking abortion at the hospital setting. There are big variation between 13 provinces. 2 months, last one is 1,800, and within 2 months, we collect the data 8,000 in China, big variation. So what is this population? You can to see the women, the tough women, think abortion near the 18,000. The age between the median age is 28, but the range, the last one, more younger one is 13, and older one is 15.8. Because today we talk the migrant from the rural to urban. Sorry, I asked this population is rural and urban to urban. So I just include this analysis. It is 14,500. So that part is the local urban. I compare between the urban population and the rural to urban population. The local urban population near 13,000. Another one is 15,000. The age, you can see also a difference. The median age is 29 for the local urban population, and the last one is younger, the 26 years. What I can say, I just to see the age is a difference. You can to see, you compare the urban is blue color and the rural to urban is red color. You can to see the woman less than 13 years is 2 or 3 among the floor 18 population. That means the rural to urban. And the 1/2 from the urban population. And the married study, you can see also, for the unmarried, the studies is more floor 18 population, is more unmarried women, the young. So what is the outcome? We can to see the repeat abortion, can to see the both population, you can to see is very higher, is near the 16.7 for the for the urban woman, and another one is 16.3 for the rural to urban population. Why they come to here for the you can to see because there are also difference between married, married and unmarried. For the unmarried urban and the rural urban, you can to see for the floor 18 population they don't use any contraceptions, but for the urban population they use, but is failed, that is inefficient, maybe not consistent use and not correct use. So the main finding, I gave the summary, the rate of repeat abortion is very high. You can see 67% in for the urban women and 63.5 among floor 18 women. But the main reason why they come here for the abortion is that they don't use any contraceptions from floor 18 women. And for the another urban population, that means they use, maybe not correct use, not consistent use. So I go to the also some publications. You can to see where a lot. Also we have the book. We use the book is the funding by IP7. The book includes all the projects from the includes qualitative study and also quantitative study. So I go to the second part is the prenatal health among immigrant women in Beijing. We call CPIP study. What is research question? Is there any effect of the maternal origin on the association between the maternal health and the risk of the preterm birth? We define preterm birth is less than 13.7 weeks gestational age. So you have to see the different, internationally we have different classification on the maternal origin. Different, what is that? Is a geographic region. You can see it's Europe. In the Europe, we are also the European Commission and the no European Union members. And also some classification use the income level, higher income, low income, and by World Bank. And also we use ethnicity, you can say black, white population. And sometimes we have also use the country of the birth, where you live, where you give your birth. And also some can use the nationality, also citizen of the at birth. This I talked the project, European Prenatal Health Report, is the Eurostat collection data in 29 European countries. It's all the indicator among the delivery, prenatal. You can see most of them use, so the classification, so we use the country of the birth is most. All nationalities at birth, all nationalities at delivery. Maybe you change nationality at birth. You get maybe I nationality at birth. I'm Chinese, but One gives the delivery and nationality is Belgian, so you can ask both information. So, but the challenge, we have got to the the same maternal opportunity. We need the large sample size. So we use the study the CBIP. What is CBIP? Is a French, is a Centre Epidemiologie Périnatale. We are connect data is a database linking the holding data of the birth registrations and hospital medical data. This is when your mother gives the delivery, all the information we collect. Then we match together. So population, you have almost near 245,000. All the single liver births from the 5 years, 2009 and 2013. What is study design is a retrospective cohort study. We just compare the mother nationalities, then we see the outcome. So why Belgium? You know, this is the Belgium is the you can to see is the largest country immigration. You can see in 2013 there's near the almost 14.5 is a woman gives the birth is not Belgian, is a foreign nationality. So it's very, especially in the Brussels. So the setting, maybe you know, Belgium we have the 3 regions. The 2 of the 3 regions in Belgium, Brussels is the capital, and Walloon. Walloon is a French-speaking community. Yeah. So what we define is a maternal origin is a mother nationalities at birth. So I just can to see you can the box plot you can compare to here is there's a variation between the maternal hair according to mother nationalities at birth. You can see it's not the median and there's 25% and there's 75% and there's minimum and maximum. You can to see there's a variation. It's very clear variation. So not just this is variation. Also you can to see the outcome per time birth among the different mother nationalities. Also there's a variation. You can to see the Italian is more higher rate for per time birth, 17.7, and for the Moroccan is only 14.5. So there's a variation. We do also this multivariable analysis. You can to see the statistics also significant even you adjust maternal age, education level, and also the parity and the BME and other things still statistically significant. So between the, you can to see for the Belgian woman, there's a statistically significant between the maternal hair and preterm birth, and also for Italian woman, and also for the Polish woman, yeah, 3. So the conclusion we can to see is the patterns of association between maternal hair and the risk of the preterm birth is varied according to mother nationalities at birth. This is finding we can to see. So we can to see the association between the height and the risk of the preterm birth is modified by the maternal nationality at birth. You can to see there's variation among regions of the world. And also variation among same income group. I got to see Italian and Belgian and the French is not same, the association. Of course, we just published these papers recently. So I talked the 3 studies, you know, before these 3 studies, a lot of big team, we work together. So I had to see, the thanks to my team, the consortium, the UNAMI is a European funding, and also impact groups, whereas also the CBIP. Yeah, thanks. 谢谢。
Thank you, Dr. Zhang. You give us so much data. I think it will take us days to digest, but it's fascinating studies. Thank you. And this is certainly highlights the importance of reproductive health among the migrants. And our next speaker will bring you to Guangzhou, which is a southern city in China. And it's also considered, this one, considered as the southern gate to China. So that's from Tsinghua University. I present you Professor Gu Jing to discuss this.
Thank you, Jennifer, for the introduction, and very nice to be here to share with you our study on health status and the service for international migrants in Guangzhou, China. A few background of the study. According to the World Migration Report, China has become the new destination for international migration. And from this figure, we can see the number of international migrants is keep increasing. And this study is conducted in Guangzhou. I don't know whether you have ever been to Guangzhou before. Guangzhou is among the top 3 cities in GDP growth in China, after Shanghai and Beijing. And in history, Guangzhou is quite open city among all the cities in China, because Guangzhou for a long period of time is one of the most important city in international the trade port, and also the only city open for foreign trade. So it attracts quite a lot international migrants to Guangzhou. According to some data, the international migrants to Guangzhou is also increasing. From this figure, we can see that many international migrants are from Southeast Asia, Africa, Middle East, and Eastern Europe. According to the Wikipedia, Guangzhou is also called the capital of the third world. So there are many people from different developing countries. And here I show you some typical photos in Guangzhou. In some areas in the city, actually the city centers, in some communities, you can find some people from Africa, from some developing countries, working and living very closely with local people. In literature, studies about international migrant health are kind of focused on developed countries, and China are always as the exporting country, not as the receiving country. And in literature, most studies are focusing on international migrants' health status and accessibility to healthcare services. And most of the migrants are usually young and healthy and may have potential high prevalence of infectious diseases. And they often encounter challenges in adapting to the foreign environment. And studies regarding migrants in China, so far, they are very limited studies and more from sociological perspective. Here I listed some literatures focusing on their social organization, Africans, their migration behavior or social support. From the health perspective, there are quite few studies in this area. So far, there are some qualitative studies, some review studies, and the key findings are kind of negative. The Africans are usually, they are mistrust to Chinese doctors' services. There are some discrimination, and they think the cost of healthcare or quality of care are not that good, and Chinese doctors may not have the ability to deal with the neglected tropical diseases, and there are language barriers. So in this study, we are trying to targeting these research gaps. China as a receiving country of international migrants, and actually there are migrants from different countries, including high income, low income, middle income countries. We want to see whether different group has different health status and there are different perceptions, and we are trying to do some quantitative studies in this group. So this is a cross-sectional study. We recruit participants from the Bouey Airport Customs in Guangzhou, and in about 1 month, we recruited over 1,000 adult foreigners entering China, and we use electronic questionnaire to do the interview. Here are some questions we asked, including social demographic characteristics, migration-related characteristics such as visa type, their number of visits to China, and their social integration in China, like whether they have Chinese name, whether they have education experience in China, social network, and health-related status, like perceived their own health status, ever had health problems in China, health insurance, and overall evaluation on China's health services. The results show that during that period, the participants came from over 100 different countries. So like in one month, the world, half of the world sent a representative to Guangzhou, and over 50% are from middle-income countries. The top 3 countries are India, Yemen, and Russia. About 1/4 from low-income countries, from Congo, Tanzania, and Ethiopia, and so, less than 20% from high-income countries, Korea, Japan, and America. Here are some bar charts of social demographic characteristics. Most of them are female, over 70%, and the low-income countries have more female population. And the average age is about 30, and the high-income countries are a little bit older. The education actually received quite high education, over 80% overall received college education or above. And when they enter in China, about 60% they already had a job in China, and more from the high-income countries as compared to those from low-income countries. Their visa type: for low-income countries, most holding crew member visa and working visa. For high-income countries, over 30% holding student visa. And about their number of visits to China, actually about 30% visited China for more than 10 times. And it's higher among the high-income country group and the lower among the low-income country group. And the number of cumulated time stay in China, about 10% have been in China for over 5 years. And the low-income country group stay in China longer than the high-income country. And here are some variables of social integration. About half, they have Chinese name, and about 40% have education experiences in China, especially the low-income country group. And their language, around 10%, they say they are fluent in Mandarin. But I think that will still have problem if they need to go to see a doctor. As for English, about 50%, they say they are fluent in English, but Chinese doctors, they may not be comfortable to communicate with foreigners in English. And about 50%, they think they are in very good health status, and the low-income country participants, they have higher percentage. And this is about ever had health-related problems. About 20%, they had health-related problems in China. And this is about medical insurance. The orange bars are they say yes, they have medical insurance. It's about, overall, it's about 40%, and the lower in low-income countries. The overall evaluation on health services in China, about 40% they think it's good, but about 22% in high-income countries, they think that health care in China is not good, it's poor. And we also studied the associations between country income level and health-related factors. Like in this table, we calculate the association between country income level and the perceived health status. After adjusting for some potential confounders, we can see that those from high-income countries are more likely to have perceived poor health status as compared to the low-income countries. And after adjusting for some potential confounders, we can see those from high-income countries are more likely to have health problems in China. And after adjusting confounders, from high-income countries are more likely to have medical insurance. And those from high-income countries are less likely to think the health service in China is good. And also we analyzed the data of the people who have actually encountered health problem in China, but I think that limited of time, I may skip this part. So, from our study, we can see the international migrants to China, most of them came from middle and low-income countries. Those from high-income countries kind of visited China more frequently, but those from low-income countries stay in China longer. And as there is a huge diversity of origins of international migrants in their culture, in their religion, language, so China is facing great challenges in provide health services to the international migrants. Especially, we don't have much experiences in this area. And from the data, we can see there is health needs. About 1/5 had health problems, but there are quite a lot of barriers. Like many of them don't have health insurance. There are language problems, and they have negative perceptions, and there are some discrimination. So there need to be some innovations in providing health-related services to the international migrants. And in our study, we find some health service model in community, because in China there are some expensive private hospitals. They can provide health services to international migrants, but many of them may be not affordable. And there is this health community. They have an international office. There is a doctor who can speak English, and he has an Africa helper who get the medical training in China. And he is kind of serving as a general practitioner. If there is Africans patients, the doctor will see him. If there is some specialist needed, he will help to do the translation. So he used WeChat to communicate with the patients to do the appointment, and he is quite famous in the community, and many patients ask him for help. So as China is under the background of Belt and Road strategy, and there is South-South collaboration, besides we reaching out, it's also important for China to take care of people coming to China. And in this area, China's experience can contribute to the world, and maybe that is also unique in the world. Thank you.
Thank you. In my 15 years working with China on public health, I found that there's definitely a shift from the emphasis on rural to urban migrants in China to now a lot of emphasis is on international migrants. So it's actually a great introduction to our next presentation. So we have seen the pattern of the international migrants to China. Our next presentation by Ilana Uriski, a professor from Brandeis University now. We had conducted some data collection last summer specifically among the African migrants.
Great. Thank you, Jennifer. So I don't have a lot of slides or data. I'm an anthropologist. Text is our data. But I want to thank Jennifer and Georgetown for coming up with this idea and bringing together people from the epidemiologic side of the room with the social science side of the room. And I think that Gujing, your presentation, was probably half of what I would talk about. So I think it gives a really, really wonderful introduction to what I want to talk about, because I want to give some context about what Gujing has been doing, and how do we make sense of all this data, and what do we do with all these people who are coming from the outside into Guangzhou and having trouble accessing healthcare, and they have certain problems, and they can't speak, they don't speak Chinese, and the Chinese doctors don't speak English, and language barriers and cultural barriers to how they access healthcare, and understanding, sort of why that's happening, but B, also, how do we bring more attention to this problem? And so I think one of the things that Gujing may have mentioned, and what I want to emphasize, is that there's so much discussion around the sort of communication between China and Africa these days. And most of that discussion happens at the level of Chinese immigrants going to Africa and Chinese companies going to Africa and doing huge infrastructure projects, and what that does to, say, the African economy and economic development in Africa, and sort of the geopolitical effects of that. And there's little discussion. I mean, you'd be hard-pressed to know this outside of this room, but there's little discussion of what's going on in the opposite direction. And I think, Mike Stoto mentioned this morning in a discussion we were having that, had he not been in this room, he wouldn't know about all the migration that's happening from Africa to China. And, it's not only you as a non-China expert. I've spoken to people who work on, the China desk in the U.S. in the State Department, who have no idea what's going on, who have no idea that there's this huge trend of migration going on from Africa to China. And so Gujing showed us the numbers. You can see the numbers of people coming from Africa into Guangzhou, but there are other, if you go outside of Guangzhou, there are other people around China as well. This should have been first, but and one of the main places that this discussion goes on is right up Mass Ave at SAIS. There's a huge center run by Deborah Brodigam, who had come from AU, and she went to SAIS, and she runs a big China-Africa Research Institute at SAIS now. And really, I would say most, if not all, of the discussion there focuses on Chinese investment in Africa and the impact of that. But here's some data that they collected, not only about Chinese exports to Africa, but also how much China is importing from Africa. And you can see how those amounts have been steadily increasing to the point, I don't know what happened, There's certainly been a downturn here, but at one point there were more Chinese imports from Africa than exports going to Africa, and so this is something that we should be paying attention to. And so I think one thing that this dialogue can help in is, how do we get more attention focused on the trend of Africans that are going from Africa into China. So one of the problems that I've seen as I've gone around and interviewed Africans living in Guangzhou, looking at the problems that Gujing just mentioned, is we talk about these people as immigrants, right? Or foreigners, they're foreigners living in China. I think, sort of discourse, academic and sort of policy-related discourse will force us towards talking about them as immigrants, but are they immigrants, right? These are not people who have actually migrated. And so I think we're forced into that discourse because that's how when we look at people who come to this country, either as refugees or as immigrants, we look at them as immigrants. And that happens all around the world. We have immigration policies. We have, there are paths to migration. There are paths to immigration here. There are immigration policies. There are organizations, both governmental and non-governmental, that offer services to immigrants here. And so we're able to look at immigrants and immigrant health being the health of people who have migrated. But how do we do that in a context where we don't necessarily have policies for immigration, where we don't have paths for immigration? And I think that's one of the things that presents challenges to us in terms of how we're looking at either Chinese immigrants going to Africa or African, either Chinese who are living. I'll try to really sort of avoid use of the term of immigration in this context. Either Chinese who are going to live in Africa or Africans who are coming to China to live there, right? We've Africans who have lived in China for 20, 25 years, who don't have status in China. We have Africans who come back and forth between China and their native country, right? We saw this in Gu Jing's presentation. So it was, short-term and long-term migrants. And so, that's one of the ways, one of the ways that I think we should, so we need to look at the infrastructure, and I thought I had this on here, but, we have all these people who are coming in, working as itinerant traders, some of them for the short term, some of them for the long term. So I think, one of the other problems we have is if we're looking to understand what's going on in this community, how do we sample them? How do we categorize them, right? And I think we need to sort of differentiate between those who are coming and going on short-term bases and those who have lived there for a long term, and understand what are the needs of these different populations, right? It's not just one population. So, they come from, right, Africans, they come from 54 different countries. They speak 3 different languages, right? English, French, Portuguese. They're from Ethiopia as well, right? So Amharic, right? So figuring out where they come from, they come from different religions, right? So there are Muslims, there are Christians, there are Catholics. They've set up churches, they've set up religious communities. Figuring out how they organize themselves, right? Most of the Africans who come are organized into some sort of a community organization, right? The Malians look up to leaders of the Malian community who are actually elected. They're elected, I think, back home in Mali, actually. Right? So most have community leaders. There's a community leader of, for Congo, for Senegal, but it's not just a leader. It's oftentimes an entire infrastructure, right? And how do we work with that sort of bureaucratic infrastructure? Not all of the communities have community leaders. The Sierra Leonean community does not have a community leader, and apparently that's sort of, from what I understand, that really accords with how they work back in Sierra Leone. So, I think the data that Gu Jing has collected is wonderful, and it sort of gives us a snapshot of what's happening and what's needed. And again, it's great that we can work together and have this dialogue, because, looking at this from a more anthropologic perspective, that's where the context comes in, and that's what I think will help us answer these questions.
Thank you, Ilana, for providing some context. We actually collected more than 40 in-depth interviews last summer in Guangzhou, and we really talked about not just the health services, but also how the system of society start to have stratifications. So given the time, the last presentation is mine, but I will make it very, very short so that we can still have some discussions. So we're coming from a lot of data to a proposal. So I'm not going to present any real data other than from the literature review. So I want to show you this map. Well, it's not that clear, but this is Myanmar, as you can see. So the proposed study that we are interested is to look at 2 borders of Myanmar, where the migrants, international migrants, going to the east, to China, and of course we are talking about Rohingyas that are going to Bangladesh. So going back to Professor Zhang's presentation about reproductive health among migrants, especially migrant women and girls. When I worked on HIV research in China, usually at the border, part of Yunnan, and Ilana has been there too, looking at the migrant women for HIV prevention. One thing I noticed is, echoes the data, is that it's very difficult to get quality of reproductive health, very difficult to get family planning. So now coming to humanitarian crisis, that's getting even worse. So what we would like to do is to look at this map, sort of conceptual frame. And thinking about outcome is the reproductive health for migrant women and girls, including refugees. And we're thinking of their health needs. And health needs, when we talk about the health needs for migrant women, we're thinking of this syndemic, sort of syndemic. We know that there's a syndemic term in the HIV research. We talk about sexual transmitted diseases, drug use, and mental health as the syndemic. But among the refugee women and migrant women, we found that specifically it's mental health, gender-based violence, and sexual and reproductive health as something always comes together. And we are talking about some of the common risk factors that's to this population. I'd like you to introduce you to Maisha, who is our junior in the government program in our college. She has done a comprehensive literature review. Would you like to say a few words about it?
Yes, for our health needs, we found that there is clearly a link between mental health, gender-based violence, and sexual and reproductive health. And SAVA is evident globally. However, there's not been much research done on the migrant population, so we want to kind of see how SAVA affects migrant women and girls. Women have an increased risk of depression in the perinatal period, so this kind of this is augmented by structures of gender violence and gender structural oppression. And migrant status affects mental illness during this period as well. And IPV, which is intimate partner violence, can also cause access to barriers and resources and contraception.
Skip that. The other side of the equation, of course, is the healthcare access. And the healthcare access and utilization are also very unique for people who are women and girls on the travel. Let's say a few words.
Yes, so we want to, again, reiterate our aim is to find SAVA and migrant women and girls and a multi-level integrated intervention using our BEST model. Because of the high rates of HIV, Hep B, and other diseases in the migrant community with refugee women, there's a really deep necessity for perinatal care. And many migrant women, they identify the health structures and in their host country as insufficient for meeting their basic needs. So there's a reliance on foreign programs for basic care and for modern contraception, and a lot of people, especially women over 35, don't actually use modern contraception, so that's a target population that we're going to be also looking at. There's also these three categories of barriers that we're looking at: financial, psychosocial, and structural. So things like citizenship, because it's unequal for migrants versus citizens and their access to care in the host country. Language, a lot of healthcare professionals don't speak the specific dialects that these refugees are coming in speaking, so that creates a disconnect between what they are understanding. And there are financial barriers in terms of transportation costs or lack of transportation, as well as out-of-pocket costs for care. And there are perceived barriers. That's kind of a big one for the psychosocial barriers. So there's gender roles, cultural, religion, and then the gatekeeper effect.
Thank you, Manisha. So if we can go to what we have to talk about is the need side. What about the supply side, right? So when we're talking about supply side, well, this is coming from two papers reviewing of the funding for humanitarian funding that's focused on the reproductive health. First of all, there are 32 million of women and girls that's in the humanity crisis settings. And there are over 118 from the left chart that you see that 118 million women in the international migration force. And then you also see that over time it's going up. And how about reproductive health funding? And this showing all this is from data from FTS, the Financial Transfer Services of the United Nations. They looked at all the appeals for funding, charity, government, and private funding for humanitarian crisis. There are actually two colors. The red one is the not funded request, and the pink is the funded request. So as you can see, overall, there's an increase of funding in reproductive health for women in the refugee status. But these funding can be broken into these different categories. So when you look into categories, then you see that, of course, the HIV going down significantly after 2010. What's increased mostly is the pink one, the maternal and newborn health, and the purple one is the gender-based violence. So most of the increased funding going to those two areas. HIV going down, the general reproductive health is basically everything that other than the other four categories. So including transition money from acute, the emergency situation to more sustainable area. So that funding also sort of going down until 2013. And the family planning is usually the smallest group. And as we see here from our first presentation, if we don't see the family planning investment, then you see lots of other health issues. Can we go to the next one? So this is also showing that these 5 categories that we'll see the maternal and newborn health get most of the funding, whereas family planning has the smallest portion. Well, there is the minimum initial service package that started in late 90s and going into implementation in 2000. Those are targeting the humanitarian crisis areas, but it's very nicely, very comprehensively prepared to deal with the emergency situation and also transition from the emergency situation to more sustainable areas. However, if you look at the funding from the United Nations, most of the funding only less than 10% are going to the implementation of full MISP, and some of the funding goes to the partial MISP. So then we found the problem in this area is certainly there's a decreased funding and limited funding to family planning and sexually transmitted diseases, and there's not much consideration looking at the syndemic that we identified that with the gender-based violence and mental health integrated into the SRH. And we found we don't have enough evidence to see there's a full MISP implementation. And also when we talk about sustainability, it's about the cost effectiveness, right? So we're talking about how to change from the team coming in to help to more of the local community and family services. And the several systematic review shows there's very, very little evidence-based research. So we proposed these 2 research questions. One of them is to look at all these comprehensive package, how they address the syndemic over there. And secondly, how these services were provided in local. So one thought we have is looking at these 2 borders on the Bangladesh and on the China, Yunnan, Dehong area. This is all focused on Burma, Myanmar, which country has a lot of conflicts, ethnic issues, so there are lots of migration on different borders. So we're thinking about, Bangladesh and China, very different political system, very different forces that are helping these women crossing the border. What is the network in different settings, how they coordinate with each other, how can we analyze this type of a network and efficiency using network analysis? So that's one of the questions. So we did talk about, we have some collaborator in China and we're trying to develop more in Bangladesh. So given time, I won't say too much on this.